So Eran Klein has an unusual pair of academic appointments. He is a neurologist at Oregon Health Sciences, and apparently once a week takes a train and changes identities to act in the Department of Philosophy at the University of Washington.
It really is a pleasure to be here with you today and to get to learn about sort of updates in technology that I'm somewhat familiar with, and then to learn about some technology that is truly new to me. I was thinking as I was listening to Hank's talk earlier, what an odd experience that was for me to sort of, and it took me a little while to sort of figure out why. And it's that I rarely get to sit and listen to another ethics talk at a meeting like this. I mean, usually there's a pretty strict quota for bioethicists. You get one, they get the slot right before adjournment, and so but in all seriousness, I actually think from President Lebrun's welcome to all the way through the panel this morning. It's the questions about ethics and the social implications of this technology repeatedly came up, and I think that's a testament to the seriousness with which the organizers of the meeting, the Rice, and really just sort of people who are kind of coming together to form this field, sort of take these questions, and so I think that's just a welcome finding for me. Hank sort of took us through some sort of higher level kind of policy and stakeholder issues earlier this morning, and sort of nicely filled out some of the landscape around some of those ethical issues. And I thought what I'd do is try to color in just a small part of that landscape by talking about brain-computer interface technology and ethics. Not because I think the issues raised there necessarily universally apply to all the technologies we've heard about already or will hear about today and tomorrow, because I think there are certainly important disanalogies there. But I do think that there are some lessons to be learned, I think, from the ethics in BCI for maybe how we approach some of these questions and maybe who we seek out for input on how to think about these issues. All right, so I do receive funding from the NIH and NSF, but the views here are my own. So I think it's maybe valuable to give a little bit of a backstory before I begin. So I'm part of this Center for Neurotechnology at the University of Washington, which has partners at MIT and San Diego State. It's ERCs, for those who aren't familiar, are these 5 to 10 year programs funded by the NSF around specific engineering questions that have some translational potential. This particular ERC is focused on implantable BCI, brain-computer interface devices. And as we sort of talked about earlier this morning, sort of in general terms, these are devices that are implanted that record neural activity, decode neural signals, translate that into information that can control devices like the neuroprosthetic that Doug showed the video of, the BrainGate system, to be able to allow individuals with speech difficulties to be able to pick out letters or words on a computer screen so that they can communicate, such as the individual in Nick Ramsey's lab pictured there, or to be able to control other implantable devices like DBS for Parkinson's or essential tremor or depression or OCD. So when this Center for Neurotechnology was started, the NSF made a commitment to exploring ethical issues alongside the development of this new technology. In concrete terms, what that meant was that one of the thrusts of the center, alongside neuroscience and computational science, was going to be neuroethics. What that meant was a little bit of a promissory note at the time, I think, but it was clear from the very beginning that they were going to take this area seriously. And so this sort of recognition of the importance of these sort of issues sort of fits with kind of a general ethos that, Hank talked a little bit about, which has emerged over the last 10, 15 years or so, that as neuroscience develops, so too must our conversation about the implications of this. And one can see that in the core Brain Initiative principles, one of which is that we need to consider ethical issues. I have a sneaking suspicion that Hank actually may have had a hand in that. So what I wanted to do now is try to dig into maybe some of the specific ethical issues that these technologies might raise. And so what I want to do is sort of take you through a couple vignettes. These are not real cases, but they're sort of realistic cases. So I ask that you sort of indulge me for a moment. So imagine Joan. So she's a 30-year-old mechanical engineer and combat veteran who sustained an injury from an improvised explosive device. On her right arm, she has an above-elbow amputation. After a year of aggressive rehabilitation at a military hospital, she volunteers to work with a research team developing a state-of-the-art robotic prosthetic controlled by a system that involves an implanted BCI. Joan works with the engineers to customize the appearance of the prosthetic to fit her needs and personality. What she says, strong, durable, and nothing frilly, but with just enough of a soft exterior that I can hold my newborn daughter. When a new model of the prosthetic is developed for improved functionality that requires extensive training on her part, she declines the upgrade, preferring to, as she says, keep that part of me just as it is, just as my daughter knows me. All right, so hold that vignette in mind for a minute, and let me present John, okay? So John's a 45-year-old man who struggled with depression since his late teens, including several suicide attempts and inpatient psychiatric hospitalizations. Antidepressant medications, counseling, and ECT have been unsuccessful. Although he is well-liked by his coworkers and supervisors, his debilitating depressive episodes has made his deadline-oriented work as a technical writer difficult to accomplish at times. These complications threaten his job security. He volunteers for a study investigating an experimental system, a closed-loop DBS system, for refractory depression, as he says, my last hope. A set of sensing and stimulating electrodes are implanted in his brain and connected to a unit implanted in his chest. The unit is responsible for interpreting signals from sensing electrodes, determining when treatment is needed, and applying a current through the stimulation electrodes. This sensor-stimulator loop detects changes in his mood and adjusts stimulation to achieve an appropriate set point determined during consultations with his physician. After implantation, John's depressive symptoms dramatically decrease, a fact he frequently shares with his work colleagues, noting, I'm finally back to being me. All right, so I'm hoping just to sort of lay those out there as so that we can sort of sink our teeth into some of the ethical concerns. So these are obviously, I mean, I think in this audience, these are obviously technologies with tremendous potential for improving people's quality of life. That said, they're also likely to raise important ethical issues. And so maybe we can sort of try to think through a few of these. So one of them that we've focused a fair bit on is what might be called identity, right? So if you think about Joan, her reason for declining the upgrade in the device, in part, is due to her sense of who she is as a person, and her identity, that she sort of views herself in one way with the current device that she has, and is reluctant to adopt a new one, even if it brings improved functionality. Or we can think about John, right, who talks about the way in which the device has allowed him to become the person that he thinks he is underneath, or a more authentic him, right? And so this is also sort of an appeal to identity. And when we think about how we usually measure the outcomes of devices in the clinical world, we don't tend to measure things like identity and authenticity. But I think there's increasing interest in the field of neuroethics in maybe trying to go in that direction to sort of find ways to look at these sorts of outcomes. So another idea we're thinking about here is privacy, right? So these devices, as was talked about by Doug when he was talking about home devices, are going to record a great deal of neural activity, right? And so, so when we think about that, it's likely that these devices are going to be recording through sort of the full range of human activity. So, so imagine Joan is not going to just be recorded when she's doing, I don't know, doing the kinds of activities that she struggles with before, but maybe it's also going to be recording her when she's doing everyday activities like going to the bathroom or having sex, right? So, we need to think about people's level of comfort with being recorded during these activities, right? Or think about John, right? So if we're trying to figure out biomarkers for his depression, right? It may very well be that we're able to record that when his wife walks into the room, his level of depression goes up or goes down, right? And we can imagine that that's something that he may not want her to know. I mean, he might not want his doctors to know. He may not even want to know that himself, right? So, I mean, are there questions about to what extent do we have a right not to know how our brains are functioning? We might think about responsibility. So imagine Jones standing in a crowd and her prosthetic strikes someone in that crowd, right? To what extent is she responsible for this? Is the engineer responsible for this? Is the person who wrote the code responsible for this, right? Or in a related way, think about her standing in the crowd, she strikes someone, and this person happens to have just, I don't know, mocked her disability, right? And she adamantly states that she did not control that device. She did not form the intention to move that device, but it happened. And so let's say we can interrogate the data, the neural data, and it seems to suggest that she did form that intention, right? So who has the authority in that instance, right? Are we going to believe the data, or do we trust her testimony? We can think more broadly, right, at issues of justice, sort of getting back to our discussion that we had earlier this morning about sort of viability and sort of costs of doing this research in different ways, right? So these are Jones and John's devices are going to be very expensive, right? Just the research programs behind them are going to be very expensive. So there's I think, a legitimate question to ask about, is this the best way to spend societal resources, right? Or could those, if what we want to do is improve people's lives, it may be worth at least asking that maybe mental health outreach or rebuilding our environment to make that more accommodating to people with disabilities might be a better use of those resources, right? I don't know the answer to that, but I think it's an important question to ask. And I think it's also, there's also a question of normality and the extent to which use of these devices might presume or reinforce certain kinds of questionable notions of normality. I mean, when we think of John's device and determining what the set point is for his device, right? How do we decide what is a normal level for his mood, right? And I think Wayne's going to be able to probably talk to this much more authoritatively than I am. All right, so that's sort of so it's one thing to sort of think about these questions at sort of an analytic or conceptual level, theoretical level, but it's another thing to go and talk to people who either have these devices, have some experience with these devices, or might benefit from these devices. So that's really been a priority of our center. And so, I guess two things, two sort of general lessons that we've learned. One sort of also speaks to the discussion during the panel about that there are some people who are sort of eager to volunteer for these sorts of research studies or to be first in line when the devices get approved, and then there are some who are much more hesitant, right? And I don't know if there's a bimodal distribution, as Hank mentioned. but we do see both. But I would say that there's also another reason behind the people who are hesitant to volunteer for these, and that is that there are groups within disabled communities affected by the devices, who might benefit or be targets of the devices, who have experience with being promised breakthroughs before and being disappointed. So that also we've sort of heard from people is a reason that they are sometimes reluctant to volunteer, and much more take the approach of I'll wait for version 2.0 and come and talk to me then. You go first, and then get it all worked out, and then come and talk to me. The other sort of general lesson that we've heard is just that there is a gratitude among people that we talk to for having gone to talk to them. So these are devices being built for people, and they want to say in that process, if nothing, I mean, one, because they want them improved and they want them to be the best that they can possibly be, but also just sort of as a sign of respect that they want to be involved. So I wanted to present just kind of a few quotes from the focus groups and interviews that we've sort of done over the years that speak to some of the ethical issues that I talked about earlier. So one is going back to the notion of identity. So we did these interviews with individuals with deep brain stimulators for treatment of depression and OCD. And this is a middle-aged gentleman with long-standing depression, who talked about, who gave this example where soon after getting his DBS, he found himself in conversation with people and sort of acting in ways that he sort of felt were callous or non-empathetic, felt like he was kind of acting like a jerk. And this caused increasing anxiety for him, because he wasn't sure whether or not that was just who he was, or whether or not that's something that was due to the device, or maybe some combination of the two. So that sort of uncertainty sort of really bothered him. And so this sort of got to the question of who he really is, right, and how he understands himself. But this doesn't apply just to the psychiatric context. I mean, this is something that we've heard with neuroprosthetics as well, right? I mean, people who use prosthetic devices often incorporate those devices into their body schemas, right? So much so that sometimes they forget that they have them. And this is something that we should sort of keep in mind as we have devices that may be controlled, right, by implanted BCIs, that this is probably going to be increasing rather than decreasing. Another thing that we've heard is notions about control over devices, right? So we sort of went into doing a lot of this qualitative research, thinking that clearly people would want more control over devices than less. We all want more control rather than less. Or at least that was the assumption. And in some ways that's borne out. So this is a really nice biography by a German academic, Helmut Dubiel, who talks about his experience with depression, and then his experience with Parkinson's disease, and then his experience getting a DBS for Parkinson's disease. And there's a little bit in there where he talks about he had the ability to turn the stimulation up or down depending upon kind of what he felt he needed. So he talks about how when he needed to walk across campus to give a lecture, he could turn the stimulation up so that he could walk faster, even if it had an adverse effect on his speech, because he wasn't speaking as he's walking across campus. But then he'd get to the lecture hall and turn it down so that he was intelligible in speaking, even if it sort of slowed some of his movements. But I think that's not always the case. So in particular, some of these quotes come from that study with DBS patients with depression and OCD, that we heard from a lot of people who really just didn't have first of all, they didn't have devices that allowed them to control, but we sort of said, would you want this sort of control? And a number of people said, no, I wouldn't want that control. I'd rather have the physician have that, the control over the stimulation parameters. I wouldn't trust myself to have the device control. I'm sure, there's going to be variation. Some people are going to want that, some people are not. But I think that, I don't think I was expecting that when I kind of went into it. The last topic I wanted to mention was privacy, just because that's so much a part of our sort of societal conversation now. And so when we've talked to people, we've sort of heard the gamut on views of privacy. There are certainly those who feel like they are very concerned about the recording of or potential recording of their neural data and the loss of that. There are also a good number of people who kind of have, I think, for lack of a better term, sort of a fatalistic attitude about this. People who say, look, the IT companies, the online retailers already have tons of my data. Why draw the line here, right? And then other people who think or sort of express the view, who really wants to know what's going on in my brain when I want to go to the bathroom, right? This isn't surely not me. It's not meaningful to me. I'm sure it's not going to be meaningful to anyone else. And then I think there are people who genuinely do recognize that there is a genuine potential loss of privacy with some of this technology, but that the trade-off is worth it, right? If you can, right? I'm a person, say with Lou Gehrig's disease. If you can promise me that you can develop a device that allows me to communicate with my loved ones or with my caregivers longer into the disease than otherwise would be possible, I'm willing to sacrifice some privacy, right? Or give me the ability to feed myself in certain contexts, I'm willing to trade the privacy for that. All right, so I just want to finish up by saying, so how is this sort of relevant to sort of the broader question of electronic devices? And already in BCI, there's sort of a push to something called user-centered design, which is essentially the idea that, look, if you want to develop devices that are going to have good uptake, that aren't going to be abandoned after they're produced, you really need to get input from the people who might use these sort of all the way along the research arc, right? And there are already a number of people. Jen Collinger in Doug's lab has done some good work here. Jane Huggins at Michigan has done a lot of work in gathering input from users of BCI. I guess the take-home message for me in sort of the work that we've done is that I'm not sure that the way user-centered design is currently envisioned, that it necessarily encompasses a lot of these ethical concerns that I've sort of talked about today. And I think that would be probably what I would sort of push for is to sort of figure out a way to sort of include questions about these sort of ethical questions and try to capture that information, capture that feedback from potential users as we build the devices. So I think I'll stop there. Just want to thank the great team at the University of Washington and our partner institutions that I get to work with. And I'm happy to answer questions.
I want to just put in a plug for one of the last things that you said here. I remember almost 15 years ago spending some time with some stem cell researchers who were working on spinal cord injury, and one of them said to me that she had this sort of shocking revelation when she realized that she had no idea whether what she was working toward in the lab was actually going to be of any actual use to the patients that she was working to try to help. I mean, she knew she was oriented the world in a positive way. She really wanted to do some good for patients, but she literally, as an engineer, bioengineer, she had no idea whether what she was doing was going to connect up with a patient in a useful sense. And she realized that, though she had a vision of what she wanted to do, which was sort of help somebody ski again, what the patients she eventually started talking to were really interested in was having a kind of continence, right? They wanted the ability not to have bladder incontinence all the time, and that really changed her ability to function as an engineer, as a researcher. And I have a DARPA grant that I'll talk a little bit about tomorrow. And when I was working, we had a workshop in March, and at that workshop, I was talking to some of the other performers from some of the other teams, and one of the things that came up for them was a deep sense that they wanted connection with the end users, the eventual end users. Now, of course, with a DARPA project, sometimes the end users are military personnel or intelligence officers and so forth, but sometimes they're also patients. And so it's great that at the Center for Neurotechnology, at which you've got this great affiliation, you've already got this connection built right in. Do you have any thoughts about how we can do a better job more broadly of connecting the basic and applied researchers in facilities with the end users in meaningful ways?
Yeah, that's a great example. So one of the things that we've done is have a quarterly talk in which we bring in someone someone with a disability to sort of talk about their experience with that. Sometimes that person has a disability that the center is working on technology that it might address. Sometimes it's completely unrelated, and it's amazing to me. There's always food there, but it's amazing to me how well attended that is, particularly by students, because this is why they get into this field. They want to help people, right? And then they start doing all the technical work and that's required to become an expert in this field. And it's sometimes easy to, it's not sometimes, it's often easy to lose that connection. So that's a relatively easy, relatively inexpensive way to sort of keep nourishing that for students. Or at least that's what we found. Not just with food, yes. Nourishing the mind.
Yeah, actually, two questions if time permits. First, I know about your center. You guys are doing great things there. Well, my question for you is the neuroethics thrust, has it really impacted the engineering? Can you give me any concrete examples in which, because the neuroethics group has said, this is what the patients care about, this is what we need to do, that it's actually impacted the engineering in a real tangible, concrete way that you can point to, or have these things just been going on in parallel?
So this is the huge dilemma in doing practical ethics, right? And particularly just in the way we fund research, is that you want to be able to point to outcomes, right? So what is the outcome of putting these ethicists in this proximity, right? And this is something that we've struggled with, because I think I think it's hard to point to a particular device or a particular feature of a device that would have been different. That said, I think what we have found is, so when we first started, it was clear that the scientists and the ethicists were talking different languages, right? We used terminology that they didn't understand. They used terminology that we didn't understand, right? But one of the things that did become evident after a while was that we became much more conversant in engineering language, and then we also started to hear uptake of engineers talking about identity, right? Or agency, or these sorts of concepts that they hadn't been part of their world before, or hadn't, at least in a formal way. And I think just having that sort of common language, and to realize that these are potential issues, I think probably has had influences in ways that are kind of difficult to measure in terms of a device feature. So I do think that we're having an impact, but so I guess another example there is that we have, like I said, we put ethicists into neural engineering labs and give them, and they for months or sometimes years, and so they're in constant conversation with the engineers who are building devices, both to sort of learn about where the technology is going, and to be there on the ground when someone says, yeah, I wonder what would happen if the device did this, right? And so to be there at that time, I think, is so valuable. But also, we've had PhD students in neural engineering who have, because of their interaction with us over years, incorporated ethics components into their dissertation. So we had an individual who had a chapter in her neural engineering dissertation on the concept of BCI illiteracy. And that would have never happened had we not been there. So I do think we have effects, but it's sometimes hard to measure.
Well, the second quick question is, well, so the cochlear implant being the original neurotechnology, there was a lot of ethical stuff written and, dealt with on that. Did you kind of take inspiration from that literature when you went to the BCI, or what was the impact of that earlier ethical studies?
Yeah, I mean, I think that's in. So my kind of the colleague that I run the neuroethics group with is a disability theorist, and this is, I mean, the experience of the development of the cochlear implant and the debates around it, I think, informed much of our early work and prompted us to start going and talking to end users probably much earlier than we otherwise would have, or at least other than I otherwise would have, not having come from those debates. And so I think that's been a very important formative conversation for us.
I also have a question that's related to cochlear implants as the sort of first device. So how do you navigate these issues of normalcy, or how do you suggest that we navigate these issues of normalcy? Because the debates with CI have been about whether or not hearing is something that we should consider a normal state, or whether we should consider deafness as just an alternative mode of being that has its own linguistic system and things like that. And so as other devices are being developed, these other issues of normalcy are likely going to come up, where people debate what normalcy should even look like, and how do you suggest we approach those?
Yeah. So I don't think there's an easy answer to that. I think it's figuring out not assuming that we know what normalcy is. I mean, I think that's probably the first step, right? Is talking to people who are the targets of the technologies and finding out what they think is normal and what they don't. And so, we did a study of researcher views on what principles ought to guide BCI technology. And so one of the ones that was quite highly endorsed was this notion of getting end user input. And when we did the study, we asked, so what does that mean? Does that mean you need to, if you're running a lab, you ought to be reading about, you ought to be appraised of the literature, or does it mean that you ought to, do one of these things where you do bring end users in periodically and talk to them, or should you have something even more formal where you have someone who's sort of in the lab with you, right? In some other formal way, and we got a diversity of views there. There was no consensus, but there's clearly different ways to do that, and I don't think there's a consensus yet on kind of how to do that.
How important is the ability to disable or remove a device, and how do you offer that in a system on which the patient may become dependent?
Yeah, so I think this is, this is something that I think device makers and funders are really struggling with, is kind of what are our post-trial obligations to individuals. In part, I think that starts with a very robust informed consent process about kind of what's going to happen when the trial is done. But I tend to think that these sorts of experiences are transformative, right? Being involved in these trials, sometimes for years. I think it's really hard for people to imagine what it would be like 2 years down the road when when the device is going to be inactivated or when the trial is going to end, and really understanding at the very beginning what that would mean. So I think the best we can do is make that informed consent process as detailed as we can, and maybe have people maybe find other ways to inform people than sort of 30-page informed consent forms.
Can I add just a couple of words on that? One of the things that's come out in particular is that so Paul Ford's group at the Cleveland Clinic has some experience with this. They've been doing deep brain stimulation work for a long time, and they've built a multidisciplinary functional neuromodulation group there that focuses on some of these issues, because some of the adverse events that they've experienced include things like folks who've been implanted with a deep brain stimulator and who've experienced some quite dramatic personality changes that were not predictable in any way. So we might hear a little bit about this in the next talk, so I don't want to say too much, but things like dramatic personality changes like massively increased impulsivity, or in a few cases where the indication was, say, Parkinson's disease or essential tremor, but the person became compulsively sexualized or a compulsive gambler or whatnot. And in a couple of cases, the way it was sort of described to me, it's off the record, was in one case the guy became just a complete asshole, and in some of the instances that Ford and Kubu and a few of the colleagues have reported on, there have been requests from the family to have the stimulator turned off. In other words, there's a remission of symptoms associated with the motor aspects of Parkinson's disease, but the side effects were so awful for the family and the patient to deal with that they were the trade-offs just were potentially just too much to deal with. So they've developed protocols to try to deal with that kind of stuff. Whether those protocols are appropriate is sort of up in the air, but nonetheless, that's sort of an additional aspect of this beyond the informed consent process, is the sort of ongoing monitoring and what kinds of experts you need around the table in order to be able to make some of those very difficult decisions.
Yeah, they are probably the premier model for how to do that.
Time for one more? Okay, another one came in online, and somebody's asking whether ethics considerations also include access for underprivileged communities and people in developing countries.
The latter is something that we need to spend a lot more attention on, and haven't spent much attention on. The former, yeah, I mean, I think this tracks the same sort of issues around disparities in research and healthcare across the board. I think there it may be particular. I mean, there may be some, maybe particularly hard in some cases with these sorts of long-term studies that take months or years and require people to come in for frequent visits, right? There are certain kinds of people with certain kinds of privilege that are able to do that, right? To be able to travel to a medical center and come to a lab 3 days a week, with a specialized van and right whatever they're coming with. So I think this is an issue that hasn't been looked at real carefully, and it is an ethical issue. It's an issue of justice. Yeah.
Yeah.
Yep.
So very interesting. So in the field of neuroethics, what is the role of the government and regulators? I've been in a lot of brain enhancement neuroethics committees in which people are saying if BCI or a neuromodulation can make you smarter, who's going to have access? Are the richer going to become smarter and richer? So in this neuroethics debate, when do you involve the government and regulators, and how is that playing, into this? Because I understand the users, but what about, is there any restriction, on how these technologies will be accessed, and so how do you involve the government or the regulators in this debate?
Well, I mean, yeah, this is this is a really hard question. I think to start off with, we need to understand what the questions are. And I think so I think right now the role of the government is to fund research into these fundamental questions, which is what the NIH, the Brain Initiative, has been doing for the last couple of years. And whether or not, and then things like the Neuroethics Society. So there was a controversy around the use of neurotechnology for lie detection, right? And this got a lot more attention maybe 10 years ago or so. And there were calls for government regulation and that sort of thing. But I think a step that happened before that is just that everyone in the field sort of came out against using this technology, but particularly before it was ready, right? And so that was sort of a way to sort of say that this is a technology, a direction that we don't want to go, without the government coming in and saying, we're deciding that this is a line that we're not going to cross. So I mean, the enhancement question for pharmacology and for devices is a really thorny one. But I don't think we're at a point yet of sort of figuring out how we want to regulate it.